and head over to Stanford, and Jason's going to present us somewhere now in the middle of the aorta.
Yeah, thanks, Sean. Thanks, Saher, and nice to see Ed and Darren. I think we're going to move our way down the aorta. It's a suprarenal case. No disclosures. Okay, this is an 82-year-old female, congenital absence of the left kidney, COPD, continued smoking, coronary disease, cabbage, hypertension, hyperlipidemia, but actually lives independently, gets around pretty well. 6 months of vague lower quadrant discomfort, found to have an aneurysm in summer of 19, measuring 4.5 centimeters. Sent over to me due to kind of continued discomfort and a CT scan done 2 months ago, right around COVID, of this suprarenal aneurysm. I'll scroll through it again here, and then I'll show you the coronals and the 3D here. Access quite calcified, relatively skinny lady from her smoking, I'm sure. And as you look at it from the top, it kind of starts right at the diaphragm, maybe right at the celiac, the single solitary kidney without any significant stenosis of those. And on the 3D here, a quite downward angulation to both the SMA as well as the renal. And if you look carefully here on the coronal, an early branch off of that lone renal as soon as it comes off. So here's some measurements cross-sectionally here. A 25 at the diaphragm, 34 at the celiac, 48 at the SMA origin, 59 at that left renal origin, the right renal origin, kind of 56 mid-aneurysm. So again, this was measuring about 4.5, about 8 months ago, and vague, quadrant discomfort, probably more from pressing on this. And so if we assume she wants to be treated, my first poll question was open surgery or some sort of endovascular procedure.
So we've got the poll question of what to do. I don't know, how about for our panel? I mean, to me, it's kind of what's their health? And then what are my options? While we had a physician-sponsored IDE here, it's a great patient to put in the physician-sponsored IDE. Now that we don't, you're going to have to get creative with commercial devices to try and do something. And so the other option is, if the lady's really healthy, open surgery is still a decent choice.
So. I think we've got a bunch of comorbidities, and an endovascular option is really nice. We've had a lot of success, and Jason, obviously, you pioneered a lot of the literature with the parallel grafting. Darren's great. Darren's on the panel, and he's obviously got a wealth of experience with his IDE and treating it with that technique. And I think either approach probably would be reasonable with this patient.
Yeah, I would agree. What's Jason? What was her renal function? Did I miss that?
Yeah, renal function baseline 0.7, but at her age, a GFR is about 45.
And that early branch on the renal artery, how important is that? It looks fairly small to me.
Yeah, it's pretty small, about 1.5 millimeters. It goes to kind of the upper posterior part of the renal.
Yeah, so I mean, whatever you do is going to require that you reconstruct the entire visceral aorta. So it's going to be 3 branches or fenestrations or snorkels. I would sacrifice that small renal artery branch, because if her renal function overall is pretty good and it's just a small fraction of her renal function, I think it's better to sacrifice that and get a good outcome and really preserve the good branch. And anything you try to put into that branch to preserve it is not going to work if the artery is that small.
Right.
So, I mean, at our center, we would use our IDE, and I'd probably use a custom 3-branch device. The vessels are downward going, a branch device would be easy to use. And also there'd be some potential challenges with fenestration just because of the iliac axis and the calcification in terms of delivering and orienting.
Yeah, twisting it, getting it oriented.
But I think it's definitely doable.
Okay, I was anticipating if anybody had wanted open, then another poll question was, if you were to do it open just at your own institutions, clamp and sew with the proximal beveled, the reimplantation of branches and kind of a Crawford approach, on partial bypass or on bypass, or some sort of hybrid debranching. I was just curious of the folks logged in how they would attack it if it was a main, or if they were considering doing open, or even those that had voted endovascular. If you were going to do it open, I was curious what the different techniques, since we're mostly vascular surgeons, on.
So I'll just comment for our own institution. And so I think when it's really truly aneurysmal at the level of the celiac, we would probably put them on bypass and be able to take each branch off individually to preserve time. When it's just one wall and you might be able to bevel it all, I might do a clamp and sew with a beveled proximal anastomosis, putting celiac as main right renal in. But a connective tissue patient or a younger patient, you're going to want all those separate. So you want to have time and ability to take your time.
Wow, look at that. A quarter for each of these, huh?
The other thing, Sean, I agree with you 100%. This is one where I think you need to put on partial bypass with distal aortic perfusion. When you get that beveled anastomosis, it's gigantic to go from that right renal to above the celiac, and the chances of future degeneration are much higher as a result. And then you're going on and off because you never can get a hemostatic anastomosis because you're going to have some fluid just because it's so long. So, I would definitely do this. And when we go on partial bypass, we always reimplant vessels. We never do that visceral patch anymore, right? If you reimplant each one, use one of those Caselli grafts. If you even have degeneration in the future, you just come in, put a covered stent across it. It's very easy. Whereas managing it with a visceral patch becomes more difficult in the long run.
And I think that's the problem when people do visceral patches. They tend to use very big grafts, and you make a patula, and very great in aneurysm. So,
or then later you have a patch aneurysm or something to deal with later.
Yeah. So I'll just remind the attendees there, you can always submit questions through questions and answers that I can pose to the poll. So don't be afraid to pipe in the question and answers to ask things so that we can pose them to the experts. It's your chance to sort of, just like you were at Viva Live in the audience, we'd be throwing around the dice to ask people what you want to ask people. So please use the question and answer. So question number 3 is.
Okay, question 3. Now that if we're choosing to go down the endo route, those of you that know me know we went down the endo route. Are we going to try to build a fenestrated device, do some sort of triple chimney, modified device, and or IDE, I guess? I should have put that as a choice, and hybrid, or a hybrid debranch.
So I guess since I know who our panelists are, Darren has the IDE. So while we had the IDE, that's always my choice. And then all of a sudden, when Matt Eagleton went to Mass General and I lost the IDE, your choices all of a sudden changed. And so I wonder for both Ed and Jason and Saher, for your own institutions, when you guys don't have IDEs, like how are you guys working on it at your institutions?
I know what Ed's going to say.
We're a big fan of parallel grafting.
I'll show you what I did so you guys can talk about what you would do.
Yeah, we've had a lot of success with parallel grafts, and it's worked well. So would go with that for sure. I think ZFEN, I see 37% responded with ZFEN. This would be a really tough case for ZFEN. I'm not even sure we could actually get it done with ZFEN just because it's so high, even with the double, even with the 2 sealing rings. Then with regulation and everything else of the iliacs, that would make it very challenging.
So Ed, for the chimneys, the Pericles data that Jason reported, once you got to 3 branches, the likelihood of endoleaks was much higher. And I've never been excited when you walk out of a chimney snorkel and you still have perfusion in the sac. Like, how comfortable can you be when it's a large aneurysm? What's your experience been when you have 3 chimneys?
So I'll tell you, whenever I see a robust GDA on the CTA, I'm just going to move forward and cover it. I'm not going to, I forgot to look whether the GDA was open here, but if it's open and robust, I would not stent it and I would do a 2 vessel. The Pericles data uses all different types of endografts. We use a specific endograft when we do it, and the results we've had have been really excellent. Smaller numbers of gutter leaks.
So Jason, take us through what you did.
Yeah. So So we've had a pretty good experience actually combining some things, and this has been on my quest to try to say that having had reasonable experience with all of these techniques, to try to combine techniques. So there was some challenging access, as you imagined. The plan was to do the renal with a fenestration, and then to do a parallel graft for the SMA. So with the challenging access, we wound up putting an endoconduit here because I couldn't even deliver the 18 French sheath through this. I had a quick poll question. If you were going to put an endoconduit, do you like to use an iliac limb, a self-expanding covered stent, balloon expandable covered stent, or a bare stent for sort of endoconduit, crack and pave, whatever you want to call it?
So while people are voting, how concerned are the panelists when you're giving up that hypogastric, when you're covering, basically with an endo solution, a type 3 thoraco repair?
Not excited about it, I'll say, because you're going to go up into that supraceliac region for a celiac.
Mm-hmm. Oh yeah, look at that, all over too. Mm-hmm. So we've liked these limbs. Actually, this one was the 7 centimeter long limb that you get from the hypogastric from the Gore IBE device, which gives you a fighting chance of trying potentially to preserve the hypo. Turned out here, this right at the bifurcation here was too calcified, and anything to try to deliver past that was going to break on the way up or on the way down. So we decided not to risk it, and knowing we might need to do that, place to drain preoperatively to do this, thinking just like Ed had mentioned that we were going to go higher up on this.
Jason, what size limb do you use, just for the audience?
It's so all of the proximal parts are 16. Remember that when you're using the IBE limb, it's flipped then, right? So then proximally, then you can choose a 16, a 14 and a half, or 12, and then distally it's 16 down there. This whole thing measured about 8 or 9, so it is quite a bit of oversizing, but in sort of in my experience, the iliac limbs can be oversized, and they don't wrinkle like a Viabond can wrinkle and create a little divot, if you will, that can get thrombus in it. I don't know what other people's experience with oversizing a Gore iliac limb. I've had pretty good results with it, like severe oversizing.
Yeah, I've actually usually used Viabond just because there's a wide variety of sizes and lengths that you can choose. The other thing that we've done in some circumstances like this is use shockwave lithoplasty. And sometimes you can modify the calcium in that vessel where you can dilate it and introduce your sheath, and avoid having to sacrifice that hypogastric and do an endoconduit. We really try to avoid sacrificing the hypogastric arteries when we're doing thoracoabdominal type work.
Yeah, so just like Ed was saying, and to Sean's point, 3 branches of parallel graft in our hands has led to a lot of gutters. So I'm relatively liberal about covering the celiac. I guess that kind of answers this question. I'm curious what people would do, and I'll tell you that actually the GDA and the SMA were obviously wide open.
So I would say I'm pretty liberal about covering it, but I have had 2 patients over the last 20 years where their stomach died and they joined it. So I have seen the sort of gastric disasters that can happen, and I'll never forget the first one was a patient Roy and I shared, and so it can happen. It's really uncommon though.
Yeah. Okay. Looks like everybody would do it based on the SMA and the GDA being wide open. Okay. So we plugged the celiac, so now we got 2 branches relatively far away from each other. So you can't just build a ZFEN for it. So the strategy then was a parallel sandwich graft for the SMA with then a custom single hole ZFEN for the renal. So the sandwich technique then, obviously you create a layer of a TVAR first. This is a short 32 by 109 alpha right up to the level of the SMA. From the other groin, then I have the SMA catheterized so I can try to land my thoracic piece as close to that as possible. Then from an 8 French brachial sheath through then the thoracic device and then with a vert catheter immediately into the SMA. So now we've got through the thoracic piece in this sandwich, a 7x79 VBX as our parallel chimney graft. With all that in place, then again, we had built a 32 millimeter ZFEN with a single renal small fen. Those of you that, when you build these as a 6x8 small fen, you can put this down 32 millimeters from the top. So you've got about 28 millimeters of fabric above the fabric of the commercially available device. So again, from above, you're in the SMA and you're in position with your 779. We place the ZFEN then through and then line up, and then you only have a single hole to line up. We talked about the difficulties of manipulation and lining up. If there's multiple holes, making fenestrations hard. When you only have to line up one, the degree of difficulty obviously becomes much easier.
Yes, can you comment on do you have a tip deflecting sheets in there?
Yeah, that's a tour guide there. That's what I was gonna, that's a 6.5 Oscore. I've switched to using these exclusively to not have to deal with all the additional radiation and stuff of trying. These things I think work really well. This is a 6.5 Oscore with 100 vert, and then we basically use this to catheterize, to get out the fenestration, to be pointed at the target vessel. Now this is further in. As soon as we get a Rosen out there safely, we switch the 6.5 Oscore to a 7 Ansel sheath. I think that drives out there pretty well. And then we get a 629 VBX into position through that renal fenestration. Curious on the panel, I know there was always been a lot of chatter between using ICAST and, if there were Europeans on the call, a lot of Bentley grafts. We've switched pretty much using VBX for all our fenestrated branches. There's been some controversy about it having discontinuous rings. Just curious what the panel thinks about VBX versus ICAST versus, if you were a European, a Bentley for a fenestrated branch.
I use both ICAST and VBX, although I still have concerns about VBX because of those independent rings. But in situations like this one, where there definitely, when you saw the course of the renal artery on the CT scan, it's a fair amount of angulation and tortuosity, and the rigid ICAST I don't think performs as well in that. And I think there's benefit to using the VBX in a situation like this.
Yeah, I could have concerns about the design, but I can tell you that, you know, when we looked at our IDE, we certainly see more fabric issues later on with the ICAST than we did with any other covered stent. So I don't think there's enough data with the VBX, but boy, it sure tracks a lot nicer.
Yeah. Okay, so then this is, again, the 32 thoracic device, the 8 French sheath, the 779 VBX in position, the ZFEN, the top is deployed, the 629 VBX is out the renal through the fenestration in a 7 French Ansel. We pop the top of it. Remember, there's only about 28 millimeters of fabric to the top of the ZFEN. So really, to make it a true sandwich, you need a lot more overlap of fabric. So then I took a cuff that was larger than both the thoracic piece and the ZFEN piece to make the inner layer of the sandwich. So now you've got thoracic piece, 779 VBX, and then the inner cuff. And then what you do here, then obviously you inflate first the 779 VBX, and then you balloon mold around. So this is now just a single sandwich snorkel parallel layer. I've moved towards this, you know, Dave Minion gets credit for this eye of the tiger idea, where if you blow up the balloons as perfect circles and then mold against it and then take down your aortic balloon, you can get these maximal types of gutters. He had this idea, which I thought was very clever, where then you take a smaller balloon after you've inflated it, and then it collapses it down more to an eyelet, if you will. And so here in this scenario here, after I've deployed the 779 VBX, I crush it. And then in this video, then I inflate a 4 millimeter balloon and then crush it and then inflate it against the larger balloon. And it creates kind of an ovoid shape, which you'll see on the CT scan here. This is a nice technique, particularly for a single snorkel or even for a double snorkel. You can make these more oval shape. Ed, do you try to do this on your parallels, or just if there's a gutter?
Generally not. I'm pretty vigorous about the kissing balloons, but I'm a little concerned about creating too small of a lumen with that technique.
Well, what I do, and I think that this is actually, I consider it a little bit of a game changer in terms of eliminating gutters when I do parallel grafting, which is uncommon. But before I crush it, I actually post-dilate it even larger in the aortic segment. So if this was a 7 or 8, I'd take it up to 10 in the aortic segment. Then I'd put the small like a 5 millimeter balloon in place, and then I'd crush it. And then you get
And it's longer
shape with a much larger cross-sectional area.
Yeah, I like that.
That works perfectly. And you also get much more of a lens shape when you dilate it bigger, then crush it, and then re-expand it.
Yeah, that's a perfect idea. Okay. So then we complete the ZFEN by molding the 629 VBX and flaring it at the end with a 9 balloon, deploying the distal piece of things. Here's kind of a final run. You can see the contrast rapidly coming down the chimney, through the fenestrated, through the downward going renal. Yeah, there might be a little hint of a gutter, a little bit of a blush kind of posteriorly. We looked at it in a couple of views. I've been, the ACT is still pretty high at this point. If it's a blush like this, generally at the first scan, it's gone, and certainly when you've reversed the anticoagulation. 3 hours, an hour and a half of fluoro, kind of a heavy foot. I have 1.6 gray, 87 of contrast, extubated trench of the floor, no transfusions, a little bit of rehab on the floor because of her COPD. Went home on post-op day 5. The creatinine did peak at 1.1 from 0.7, but came back down to 0.9 post-op before going home. Here's the scan.
That's commendable. 3 hours. That's fast you did a lot of work there.
Yeah, we have a pretty good team now. We always have an arm team and a groin team, and it's 2 attendings, and I kind of like doing it that way. It's a cleaner way to do it. You can see as we slip by the eye of the tiger there, its lens is pretty collapsed there. I actually was concerned about that, but she was eating and happy as a clam. Here, I'll slow it down here as we get through this, and then the 3D shows it. Nice. So then there's the thoracic piece. It's sealed there. And then inside, right there. So that's the layers of it. And then down, there's the plugged celiac. There's the SMA. And then here's the fenestration for the renal with a flare. And then the renal's filling nicely. A bunch of, I think some of those dark spots are that branch that was taken out. But again, even in 3-month follow-up here, or 2-month follow-up here, creatinine's been stable. Here's the view of that lens-shaped SMA, and then here's the 3Ds of that. So I'll end it at that.